I would like to thank the organizing committee for giving me the opportunity to be here and talk to you guys about the practice of nuclear medicine in Kuwait. In fact, I'm running out of time, but hopefully I'll give in particular our visitors a broad scope about our practice in nuclear medicine so that we can discuss the similarities and differences and how we can go further in the process of technologist education. In fact, I'll be talking about the practice of nuclear medicine in Kuwait in general. I'll try to focus also on technologist education in the Faculty of Allied Health and how also ourselves have a challenge in nuclear medicine technology education, especially with the multimodality technique arise and the evolving fast development in the field. Okay, the organization of the hospitals in Kuwait, very important, I have to show this slide, that it starts with a hospital manager, who is usually a physician, then goes down to the different department. If we talk about NM department, we have the head of NM department, who is a physician also. Then we have the chief technologist and other administrative workers, medical lab technologists, radiopharmacists, and technologists working under the umbrella of chief technologist. The nuclear medicine service started late 90s when we had rectilinear scanners and we used to do mobile camera imaging. Also, we used to do thallium as myocardial perfusion imaging. Now we switched to new equipments and also development in the imaging procedures. Currently, we have 11 NM departments in Kuwait. 9 provide general NM service. What I mean by general is different imaging procedures, including PET imaging, in particular cardiology, oncology, and sometimes brain imaging. We have 2 specialized, urology, kidney center, and chest hospital. In the chest hospital, we mainly do myocardial perfusion imaging using citrofosmin or system MIBI. We have also, I have to highlight, we do not have a pediatric hospital in Kuwait, but in general hospitals, we usually have pediatric patients done within a daily procedure. Mainly, we have government hospitals. We have only 2 private ones. One is molecular imaging. It is in the process of establishment. And another one is from Yako Company Hospital. Current machine, we have 4 PET CTs. We have 6 PET SPECT CTs, 30 SPECT, and 2 cyclotron. Our production is mainly for FDG, fluorine-18, and NAF. The imaging procedures, usually each hospital has its own manual. However, in fact, I have to say that based on the physician's education, whether they are European or American, we use European or American guidelines from SNM. However, in these imaging procedures, usually imaging factors and parameters were set up. Preparation might be different from hospital to hospital. However, we never meet. You've been, Georgia, talking about European Union and different countries, but hospitals in one small country like Kuwait, we never decided on one manual to follow. Each hospital has its own, but we are following under the umbrella of European or American, or sometimes we put our touch and flavor on it. We have Central Radiopharmacy Unit established recently, where it controls and organizes the distribution of the radiopharmaceutical among Kuwait, also to limit number of the waste, to better manage the waste out of the hot lamps. So the Central Radiopharmacy has been established. We use European dose card, as you mentioned, Giorgio, for pediatric, and sometimes we use North American consensus guidelines, or sometimes we use European task force guidelines for dose measurement for adults. But I think a European dose card, but people do not know that they use European dose card. Okay, we have medical physics unit. In fact, the job of the medical physicist is not well established in Kuwait. Although we really need medical physicists, but it's the higher authority does not usually. We have this pressure and the decision from higher authority, and these people do not appreciate the job or the role of medical physicists in NM department. Maybe only in radiotherapy, because we do dose measurement and Linux, so they appreciate that part more. Therefore, we rely on a medical physics work on manufacturers, application specialists from different vendors. It depends on what kind of machine you're using. Radiation protection. We're using IAEA rule and International Committee for Radiation Protection rules, but we are also following the Radiation Protection Department from the Ministry of Health. Each department has its own radiation protection officer, making sure that all the safety measures has been taken in the department, and they are responsible from the radiation protection department in the Ministry of Health, where they issue license to run NM service, provide personal dosimeter devices and monitor readings, and they do periodic inspection as well. Okay, the staff also is growing since 1990, after the occupation. We have 117 NM technologists. We have 73 Kuwaitis and 44 non-Kuwaiti. 73 Kuwaitis, mainly they are graduated from Faculty of Allied Health. Not because we do not accept non-Kuwaitis, but because we are limited with numbers each year, and usually Kuwaitis apply for this faculty with a certain GPA. As you notice that we have 50 NM physicians from residents to consultants. I remember when I worked in 2000 in UK, we could rarely have an NM physician in the department of Aberdeen. Also, so we have to go to fetch for the MRI physician to help us, and medical physicists to interpret the data. But nowadays we have 50 NM physicians from residents to consultant, thanks to the Kuwaiti Board of Nuclear Medicine and the Master of Nuclear Medicine for Physicians. And the ratio is 23 to 10, 2.3 to 1, means we have a big number of physicians compared in relation to the technologist. The promotion system of NMTs with bachelor degree. Usually, we have only bachelor degree program in nuclear medicine. We don't do associate like Britain or other European country. They have to go into 4 years of education. The promotion system in the Ministry of Health, which has nothing the faculty to do with it, is the entry-level practitioner who has no experience, and they jump every 2 years or 4 years with different job title: practitioner, senior practitioner, specialist, senior specialist, and chief specialist after 18 years of experience. I should say that we have a nice job title written on a paper. However, the transition between these job titles are vague. So sometimes the administrative work and the managerial work or research work or even the student education, it's embedded inside these job titles, which are really vague for any technologist to read and understand what performance or skills or knowledge he should have to have this transition. So this transition is automatic by just years of experience. It's nice to know how this happens in the state and European Union. The NMT job description I talked about as well. The NMT usually perform imaging procedures, prepare, calibrate radiopharmaceutical, do computer processing, ensure radiation safety, quality control of NM equipment. The entry level of a nuclear medicine technologist can do all of this, where sometimes Europeans consider it as advanced. But again, with a CT, shall I consider it advanced? No, still our entry based on their education, still they do CT. However, in a nuclear medicine in Kuwait, technologists are not allowed to inject radiopharmaceutical. This is based on radiation protection department. So as a faculty members, we are even not allowed to teach the student to inject radiopharmaceutical, because the drug administration is the role of physician and nurses, not technologists. So even if we want to teach this and people struggle through who is injecting a radiation dose and who will be involved, again, we are in a dilemma, and we like to discuss it, guys, with you as well. This is really a challenge with a CT involved in a, while the nuclear medicine technologist has a very big role in radiopharmaceutical preparation, calibration, and imaging procedures, quality control. Again, CT is a challenge for us. In Faculty of Allied Health, we decided to mingle our student with a radiography student, because we do a program with a general 2 years and separate third and fourth, but nowadays we are trying to have them in one class because the border disappeared between the two careers, especially with the introduction of MRI soon in the future. Nuclear medicine, we need to train them. The training also is a dilemma, because is it our role as educator, or there should be a professional body? And you, George, you talked about different committees. This one does not exist, and usually are physician committees. So I think we should have, by now, with the development in the career, we should have a committee for nuclear medicine technologists to understand what role they should have in the hospital with the new equipment they're having and the relation between radiography and nuclear medicine. I'll go through that. Okay, and the dilemma also, who is going to do the CT? Shall we bring a CT technologist to do it? We're going to have a few one. And the CT technologist would manage to do a nuclear medicine imaging procedure? That is not true. So we do not have somebody who is not holding a certificate to come and do the study. So the patients really in our department are in a safe hand, I should say, because only nuclear medicine technologists who have a certificate is doing the study. However, the CT, that's why you keep the interference to CT as minimal as possible by following manufacturers' regulation of minimizing the dose, pediatric, adult, BMI, high, large, and other specification of dose limit. Okay, the education and training, as I said, in the nuclear medicine program, we have 10 years ago, we really developed the curriculum to keep up to date with the development in the career. We had radiobiology, general anatomy, NM physics, SPECT, and PET, and radiopharmaceutical quality assurance. Now we have introduced, the students are having CT physics, cross-sectional anatomy, MRI physics, also preparing them for the future. It's too much for them, but this is what they have to face, and this is really a challenge. We do computer application of CT, computer application of MRI. We do clinical practicum, competency in PET-CT. However, we do not have time to do competency in CT. That is why we do not consider our graduate are competent in CT, because they can do it on job training, or I think it's not the role of the faculty, it's the role of a professional body to train the student beyond their initial training. Okay? Okay. Um, okay, I'll go fast. Accreditation program. We are the hospitals are under the process of accreditation by the Canadian surveyors, and they are doing fine. As Mubarak Hospital, Chest Hospital, has been selected as the best department among the whole hospitals for following the standards regulation. We have this preliminary report, the accreditation of Faculty of Allied Health. We are benchmarked with Australian University because the European and American didn't allow us to do accreditation. Sorry, guys, I have to mention that. So we got, even our faculty is accredited against Australian universities. Okay, motivation of NMT, I have to say, is a part of discussion. We have published a paper about issues affecting motivation of nuclear medicine, and I have to say that our students, our technologists are not motivated because of the conflicts that you mentioned, Giorgio, and the career, and we can discuss that later. Yeah, thank you very much.